I would like to request Dr. Silima. She's most dynamic practitioner of she's an endocrinologist attached to Calcutta Medical College. Thank you, ma'am, please.
Okay, welcome to this exciting session on unmet needs in diabetes, which is the role of injectable combinations or co-formulations. And this is a new and interesting topic. For this, our speaker is Dr. Silima S Tarenia, who will be talking on this subject. And I'll ask all the delegates to welcome Dr. Sukumar Mukherjee. Professor Sukumar Mukherjee is a very respected senior person. Please welcome him here.
Thank you, sir, for the kind introduction. Good morning, everyone. And at the very outset, I would like to thank the organizing committee of AAPONCON and the supporting partner, Sanofi, for this opportunity. I'm sure we are aware of the depressing circumstances outside, but we are all standing in solidarity, expecting justice to prevail. So with that, I have been entrusted to speak on addressing the unmet needs in diabetes treatment with the innovative injectable combinations. So basically, despite so many tablets, OADs, various insulin regimens available in our therapeutic armamentarium, still the glycemic control remains suboptimal for many people with diabetes. So what is the issue? Especially with patients with diabetes, what happens is if there are insulin regimens which are complex, it is associated with multiple injections. It is associated with multiple injections which might be bothersome for the patient, multiple pricks. Secondly, the flexibility is reduced because if we have 3 to 4 shots in a day, then it might really be disturbing and challenging for the patient. And last and not least is the risk of hypoglycemia and weight gain. Along with it, say the patients, they are not engaging in daily physical activity, lack of dietary regularities, and lifestyle adjustments. So, if we can come across a drug which is going to take care of all of these put together, that is especially the so-called side effects of insulin, that is the multiple pricks, controlling the glucose levels without causing any significant hypoglycemia or weight gain. So what is this combination injectable that they have come up with? It is 2 titrable drugs. I would rather say these are 2 drugs which are put in a proper ratio. It's not a fixed dose combination, rather it's a fixed ratio. That is a basal insulin, glargine, which is predominantly targeting the fasting, and a GLP-1 receptor analog, that is the lixisenatide, these 2 being combined together as a combination injectable. So they have come up with this iGlar-Lixi, where GLAR stands for the glargine and Lixi for the lixisenatide. It is a combination of insulin glargine U100 plus lixisenatide. This is approved in India. Now, so we are all aware of the ominous octet, that is the pathophysiology of diabetes. So what happens here is we need something that is going to take care of the majority of the issues, and that would be a boon to us. For instance, if we look at this comparison, this combination, that is we have insulin here. The pointer is not working, I believe. So we can see that in the insulin arm, what happens? When the patient is being given glargine, the hepatic glucose production, the neoglucogenesis is prevented, there is greater glucose uptake in the muscles, and the lipolysis is inhibited. So these are the actions which are taken care of by insulin. Coming to the GLP-1 receptor analog, so we all know that it causes glucose dependent insulin release. I need the slide and the pointer. So here we have already discussed that insulin, it brings about reduced hepatic glucose production, reduction in neoglucogenesis, increased glucose uptake in the muscles, and decreased lipolysis. Whereas the GLP-1 receptor analog, it causes increased glucose dependent insulin release, decreased glucagon release, increased satiety, and decrease in the gastric emptying. So if all these actions are put together, then we can see that majority of the pathophysiologic mechanisms of diabetes are taken care of. So how does this complementary mode of action in the combination of basal insulin plus a prandial GLP-1 lixisenatide provide a rationale for this combination? So here we can see that we just discussed that it addresses multiple pathophysiological defects. Secondly, both the fasting and the PP glucose control, because the HbA1c control is influenced by both fasting as well as postprandial glucose. So the glargine is predominantly targeting the fasting, and we all know that GLP-1 receptor analogs have a very good postprandial glucose control. So both the fasting and PP glucose are taken care of, which leads to effective HbA1c reduction. Many people are achieving the glycemic targets. A very important issue here, or rather I would say a boon here, is once a day dosing, because whenever we come across patients who are getting multiple subcutaneous insulin infusions, say for instance a glargine and 3 shots of regular, say for along with it we are giving a GLP-1 analog, that would give us 5 injections. If a patient is getting glargine and along with it the patient is getting a injectable GLP-1, that would be 2. So if we combine 2 injections in one, then it reduces the number of pricks. Weight benefits, because a GLP-1 analog has a neutral effect on the weight, or to a greater extent it reduces the weight. So if there is any so-called issue of weight gain with insulin, that can be taken care of. Last and but not least, no additional risk of hypoglycemia when we compare it versus intensified insulin regimens. And another thing that some of the studies have shown, that there is improved GI tolerability, that Kaushik sir was just discussing, that the GLP-1 analogs are associated with greater amount of GI intolerance, because in majority of the cases we do encounter patients who had to discontinue the GLP-1 analogs because they could not tolerate it. Either they developed intense nausea, vomiting, or for the matter they had to discontinue the drug. So it has been shown that when lixisenatide was used as a combination injectable with glargine, the episodes of GI tolerance had improved to a significant extent. Now coming to what the guidelines have to say. So the ADA 2024 suggests that the combination of basal insulin and a GLP-1 receptor analog has potent glucose lowering actions and less weight gain and hypoglycemia compared with in other intensified insulin plans. Coming to the AAC or the AC 2023, here also they have suggested that if glycemic targets are not achieved with the above therapies, that is OAD or a GLP-1 array, basal insulin should be added alone or as a basal insulin GLP-1 receptor analog combination injection. So more or less all of these guidelines are in favor of the fact that we might choose to use a GLP-1 array along with a insulin either as an initiation tool, or we might as well use it when the patient is failing despite being on several OADs or insulin. Now coming to the evidence, so this will be a lot of data, I'll just try to briefly summarize. So iGlar-Lixi, the topic that we are speaking about, the combination of glargine and lixisenatide, we have a lot of trials which are there to back up as evidence. So we will first be going through the iGlar-Lixi in type 2 diabetes patients versus IDEC-ASP, because IDEC-ASP is been in use for quite some time. So this slide looks a bit busy, we'll just try to capture the essence of it. This is the SOLID randomized control trial where glargine lixisenatide versus degludec aspart efficacy and safety was seen in patients of type 2 diabetes. So what was done here? Adult patients with type 2 diabetes greater than 3 months who are on a stable dose of metformin along with a second OAD, which can be anything. It can be sulfonylurea, AGI, DPP4, etc. with a BMI less than 40 and a HbA1c, which was divided into 2 types, either 7.5 to 11% if previously the patient was on metformin and SGLT2I, 7% to less than 10% if the patient was on metformin and a non-SGLT2I OAD. After the screening was completed, the patients, they were randomized into 1:1, one arm receiving iGlar-Lixi once daily and the other receiving IDEC-ASP once daily, and they were receiving metformin plus SGLT2 in the background. What was the primary endpoint? Non-inferiority in HbA1c change from baseline to week 24. So now we'll just briefly look at what are the secondary endpoints. The main endpoint, that is the primary one, whether the HbA1c reduction is at least non-inferior. The second efficacy endpoint is if there is any superiority in HbA1c reduction from baseline to week 24, if there is any superiority in body weight from baseline to week 24, and if the proportion of participants to reach HbA1c less than 7%, what was it at week 24? So the essence is mostly we are comparing with the previous injectable and we are seeing whether there has been a similar reduction in HbA1c first of all, and whether there has been a better reduction in HbA1c along with the weight loss and no hypoglycemia. Other secondary efficacy endpoints were that if there was a change in fasting, this is where we are looking at the components separately, change in 7-point self-monitoring blood glucose, proportion of participants reaching HbA1c less than 7 at week 24 with no hypoglycemia, and total insulin dose. Last but very important is safety endpoints, because according to the ADA we have hypoglycemia events which are divided into level 1, level 2 and level 3. Level 1 is when the patient is having an attack less than 70 mg per dl blood glucose level but greater than 54. Level 2 is less than 54 mg per dl, and level 3 is when the patient is needing some assistance. Blood sugar levels are less than 54 but assistance is needed. So this was the safety endpoint. Baseline characteristics, I am not getting into the details, they were similar amongst the two groups. Now, so what did the SOLID study show? That there was a superior reduction in HbA1c from baseline to week 24 with IGLAR-LIXI. So two of our endpoints have been achieved. A, it was non-inferior, and B, it is superior. That is the first point. Coming to the second one, body weight. So glargine and lixisenatide, they have demonstrated a body weight benefit versus IDEGASP. So there was a greater body weight reduction from baseline to week 24 with IGLAR-LIXI. If we see all the p values over here, it is significant. The one in purple, that is the glargine lixisenatide combination, and degludec aspart is the one in orange. So if we look at it, then the secondary endpoints also, with the patients reaching HbA1c greater than less than 7%, less than 7% without body weight gain, less than 7% without body weight gain, and no hypoglycemia. So in all of these parameters we can see that the bars in purple, that is the one which is standing for glargine and lixisenatide combination, is scoring over. So not only it is the HbA1c alone, but HbA1c along with these factors have also shown benefit. Now coming to the 7-point SMBG values, here also there was a scoring over of the IGLAR-lixisenatide combination in comparison to the IDEG-ASP. This is the SOLID study. Finally, lower mean total insulin requirement was required to achieve the same target in the glargine-lixisenatide arm. Coming to the incidence and events of hypoglycemia, including nocturnal hypoglycemia. So here we can have a look at the ADA classification also, and overall it was seen that the incidence of hypoglycemia was also lesser in the IGLAR-LIXI group compared to the IDEG-aspart group. So what is the summary and conclusion? In the SOLID, which is a 24 weeks head-to-head study, this was conducted in Chinese type 2 diabetic patients, suboptimally controlled on OADs. IGLAR-LIXI, that is glargine lixisenatide, had demonstrated versus premixed insulin degludec aspart non-inferiority and superiority of HbA1c, superior body weight, more patient achieved composite endpoint, lower risk of hypoglycemia, no unexpected. Lixisenatide is being compared with individual components, that is IGLAR-LIXI with either glargine or IGLAR-GLICI versus lixisenatide. So here also patients with type 2 diabetes who are receiving metformin plus additional OADs having the HbA1c targets between 7.7 to 9 and 7.5 to 10, they were randomized into 3 arms. That is, one arm receiving lixisenatide plus metformin, the other one glargine lixisenatide plus metformin, and the last one glargine plus metformin. So basically the target here is glargine versus lixisenatide versus a combination of lixisenatide and glargine. Here also the primary endpoint was non-inferiority in HbA1c change from baseline to week 30. So this is a very complex slide, but the essence is that it showed superior glycemic control without increasing weight or hypoglycemia risk comparison to the individual components. Now I would be taking you to the last study, that is, we have discussed glargine lixisenatide versus degludec aspart. We have discussed glargine lixisenatide versus the individual components. Now the last one, SOLI-MIX study, that is glargine lixisenatide versus BIASP 30. So here patients of type 2 diabetes greater than 1 year, 18 years of age, were randomized after screening of 1 to 2 weeks into IGLAR-LIXI once daily versus BIASP 30 twice daily. and we need to look at what our findings were. So here again, it has shown superior HbA1c reduction and weight benefit versus the bias. This is the solo mix study. Also the secondary endpoints and hypoglycemia was attended to. I'll directly go to the summary of this study. There was better glycemic control and weight gain, less hypoglycemia, fewer injections, and it is this Iglar-Lixi is an efficacious, simpler and well tolerated alternative to premix biasp in uncontrolled T2DM. So basically all of these studies put together are indicating one thing, that this combination injectable is rational, and also it has shown greater degree of HbA1c reduction in comparison to the other combination injectable. At the same time, hypoglycemia, weight gain issues have been taken care of and glycemic control is achieved. So I would just give a few seconds regarding the structure of the device that is used. So it is available in the form of a fixed ratio. So 2:1, that is 2 units of glargine would be in proportion to 1 microgram of liximatide. This pen is a one-time use pen, and the maximum amount of insulin that we can be dialing is up to 40. That would be comparable to 20 microgram of liximatide. So a 3 ml pre-filled pen contains 300 units of glargine and 150 microgram of liximatide. And how do we titrate this? Titration is exactly the way we do with other insulins when we are titrating, that we look at the fasting target. If it is between 80 to 130 or 100 to 130, it is fine. If it is greater than 130, we increase by 2 units. It's either in 3 days or we can adjust it in about 7 days time. And it is to be given at 1 hour prior to the most major meal in a day. If it is missed, then we can give it in the next meal. If we want further details about this, I can discuss later. So I have discussed the dose titration. Now coming to the special population, which is very, very important because this is something we encounter on our daily basis, elderly patients. It can be used safely in elderly patients. There is no adjustment of liximatide which is required based on age. Coming to renal impairment, we do not have robust data on end-stage renal disease. Majority of the data states that up to a eGFR of 30 we can use it safely. Some studies claim that beyond 15 we cannot use it. Some studies claim beyond 30 we cannot use it. Coming to hepatic impairment, obviously in the last stages, that is the child park classification 3, we cannot use it. But in the initial stages of hepatic impairment, it can be safely used. Pregnancy is an absolute contraindication. It should not be used during pregnancy. The potential risk is not known. If a patient wishes to become pregnant, we should ideally stop it and give the patient either a metformin along with insulin. So it's a 1 injection once daily to be given 1 hour prior to meal. So to summarize, Iglar-Lixi is a synergistic once daily combination injectable of basal insulin glargine U100 and a GLP-1 liximatide, provided effective fasting and PP glycemic control. SOLI-D trial indicates that Iglar-Lixi is simple, well-tolerated treatment, has shown better glycemic control with added body weight benefit and lower risk of hypoglycemia compared to IDEG-ASP. SOLI-Mix trial indicates that Iglar-Lixi is efficacious, simpler, well-tolerated, provide better glycemic control with weight benefit and less hypoglycemia compared with twice daily bias. Thank you for your patient hearing.
Thank you for wonderful presentation. Before I open this session for the audience questions, I have very simple questions. It is usually agreed that for the OAD failure, if you think about the injectable, either you go for a basal insulin or you think about GLP-1 analogs. And if either of them fails, then go for the second option. That means if the basal insulin fails, go for the GLP-1 analogs. So since this is a combination of both the basal insulins and GLP-1 analogs, why do you want to put this molecule?
So sir, basically we are getting the advantages of a synergistic molecule. That is, in one shot I am getting one insulin, that is the basal one, which is targeting my fasting. Secondly, I am getting a molecule which is predominantly targeting the postprandial. And like we know that the HbA1c is influenced by both fasting as well as PP. So my fasting and HbA1c PP both have been taken care of, which is giving me a robust glycemic control. Coming to point number 2 is that sometimes with insulin we do face issues of hypoglycemia when we especially give the short acting ones. Along with it there are some issues of weight gain. So this is also taken care of by the GLP-1 molecule, which is an advantage. Last but not least, thinking from the patient's point of view, a multiple injection is always an issue, be it be us or the patients. Either there is inertia from the physician for the sake of multiple injection, and I think, sir, price would also be a consideration. Because if we look at individual GLP-1 molecules, it is, at least as of now, whatever is available is quite off the pocket of a normal population. But a glargine and lixisenatide combination, at least what they are promising, that if it can come in a reasonable value, then that would give us another motive to initiate.
So you are probably asking for placing this molecule in basal insulin failure, where you need prandial control also.
Probably yes, sir.
Yes.
That would be my take.
So now the session is...
Nice presentation, and I think half of my questions answer has been already given by Silima. So I got one question. In the era of treat to benefit, not treat to target or stepwise step approach, now it is a treat to benefit. So you should have a SCVD benefits,
Yes,
you should have heart failure benefits, you should have a CKD benefits. So in that situation, over what situation, as you have partially answered the Sandeep's question, that in that situation you are going to use price is a concern, but in this era of treat to benefit, where you place in
Yes,
front
sir.
of I can say dulaglutide or semaglutide or the next generation tirzepatide and the retatrutide, which are still on the pipeline. Of course the tirzepatide is in the market, but about this dulaglutide or oral sema or injectable sema, that is, so where you will place in front of that. Cost is a factor. I'm talking of the science. In the era of treat to benefit, where you will place it, because there is no CV benefits with this molecule,
Yes, sir.
only postprandial reduction is there. So where we stand.
Thank you,
What
sir.
is
I
it?
think, sir, your question itself says the answers, because with lixisenatide, the trials that was done, it only showed non-inferiority. There was no superiority, there was only non-inferiority to cardiovascular benefits, and also with hospitalization due to heart failure, there was no such extra benefit that was seen. So if it comes to cardiovascular safety being because we have been seeing a paradigm shift. Previously we used to target the fasting PP, but right now the cardiovascular safety, the renal safety, many other things are being taken into consideration. Small trials have shown that lixisenatide in a group of patients has shown to reduce microalbuminuria, but there was no data in kidney benefit. And coming to the main, that is the cardiovascular safety, unfortunately till now it is only shown to be non-inferior, sir. Sir, you might like to add anything to it? Thank you, sir.
In India, we have lots of obese patients and MSLD, maladaptive steatohepatitis.
MSLD.
Okay, and we need weight loss. Okay, and I think if we separately give ultra long-acting U300 glargine, which is weight neutral and cardiovascular safety, as well as liraglutide, I think it is better. And here there is no clinical data for weight loss for lixisenatide.
So,
We have tirzepatide, and we have other injectable semaglutide for weight loss. Is there any clinical data for lixisenatide? Lixi?
so few studies have shown that it has an effect on weight loss, but separately on the MFLD parameters, it is not known to me if lixisenatide has got any added benefits, but we can assume that it can bring about a reduction in hepatic steatosis as a mass effect, as a class effect. But coming to the fibrosis, I do not think any molecule as of now is known which can reverse fibrosis.
What is impact of U300 glargine with liraglutide combination or separately? If you give
Regarding?
liraglutide and U300 glargine,
Yes, sir.
if we give in
For-
comparison to this molecule, what is your suggestion?
So my suggestion is a generalized one, that is wherever glycemic control is required in the background of not wanting hypoglycemia or weight gain, and a molecule where two have been combined into one. But separately in terms of MFLD, whether there is any hard data, it's not known to me. In that case, I'll have to look up and discuss.
U300 is more basal, more fasting control, I think.
Pardon, sir?
U300 glargine, it is called Tugio.
Yes, sir.
More basal, more fasting.
No, actually, sir, the issue is that with U300, it is almost the same dose that we use with U100. It is just that the peak will be lesser and there will be lesser hypoglycemia. Because the amount which is required is very less. That is the thing. The overall amount as in the form, not that the doses are different.
Silima, excellent again. The one important thing is that it is a fixed dose combination. So whenever you are increasing the dose,
Yes.
I think you are increasing both the GLP-1 as well as the basal insulin. Is there any chances of hypoglycemia in anywhere?
Sir, absolutely we cannot say that there is no chance of hypoglycemia. That cannot be told for any medicine in any background. Say if the patient is having a mild CKD, if the patient is having a mild hepatic failure, it is an elderly patient who has not taken meals for a long time. So that cannot be told, but yes, of course, compared to the congeners which are available, because neither of these molecules are known to cause they are not potent molecules to cause hypoglycemia, so we can safely assume that chances of hypoglycemia will be much lesser.
Yes. Another issue is that if you start giving, that means basal insulin requirement in certain patients require more. So here we cannot
No, then sir, that adjustment cannot be done.
Yes.
It is
There
up to 40 we can
yes,
go,
yes.
and with 40 it will reach the maximum dose of liximatide, that is 20.
So there are a lot of
Okay, I think, sorry to interrupt Kaushik, because of paucity of time we have to close down this session. Thank you so much for your active participation.